can put, so then I'm going to pause this.
All right. So I'm going to be giving you guys a talk on chronic cough in children, and so something that you guys will see plenty of in primary pediatrics, and also you'll know kind of when to refer to us, and also get a little bit of board-specific types of just topics and concepts that should really be helpful for you guys as you move forward. And so to start with chronic cough, this is Chevalier Jackson, who's been called the father endoscopy, and he actually has a collection of things found in airways and also in GI tracts that have been picked up over the years in Philadelphia. So if you guys need a bucket list type of thing to do, go to the Mutter Museum in Philadelphia and you can see 2,000 things that have been taken out by this guy from people's airways. That said, principal complaint he said the cough is the watchdog of the lungs. And you'll see that you guys get a fair number of these patients in your office because they comprise about 7% of pediatric office visits. And so the way that we kind of loosely define chronic cough is that lasts greater than 4 to 6 weeks in duration. But I think that was deemed, at least initially, because it felt to exclude many but not all of uncomplicated viral infections. But more and more data has been coming out recently that some of the common respiratory viruses like RSV and rhinovirus and other things where they're doing a little bit more highly advanced and next generation types of studies looking at lung function, they've shown that there's actually symptoms that can last up to 6 to 12 weeks in duration. So all that said, chronic cough, tend to think of it as at least longer than a month, but usually it's been something that's been around for a couple months before you would even deem it something along those lines. In terms of cough itself, really the human body has developed protective mechanisms by which the lung will clear secretions, debris, and other inhaled matter. And this is the primary reflex that tends to take over when ciliary function is lost or impaired. And for those of you guys that are wondering the most common reason why ciliary function would be impaired, any thoughts?
So.
Actually, that's probably number 2, but viral respiratory infection is actually one of the key things that happens is ciliary beat frequency actually decreases. And so kids that do have viruses are more prone to bacterial, like say bronchitis or tracheobronchitis type of infections, those types of things, largely because that ciliary function is a little bit impaired. Ciliary function, too, is something that, if you think about things in terms of evolution, that was something that developed well before anything like a cough reflex would have. And so the cough reflex is something that humans and other mammals have developed to help with clearance here more recently. And so that said, the cough reflex tract is something that's fairly elegant, and it involves multiple portions of the nervous system to actually initiate a cough. And so there are cough receptors, and these are things like rapidly adapting receptors, slowly adapting receptors, C fibers, other things that you may have heard about from back in med school. They tend to be concentrated, though, in areas with the highest likelihood of coming in contact with other types of foreign material. So, for instance, the large and medium-sized airways, and in particular at sort of the bifurcations or the branch points of airways where those types of matter of debris will tend to accumulate. Interestingly, there's also cough receptors in the external ear canal. There's some that are present within the pharynx and hypopharynx, and also a lot of more recent work has looked at where cough receptors may reside in the esophagus, in particular sort of the lower esophageal sphincter near the diaphragm, and how that plays a role in things like acidic reflux and also non-acidic reflux. So this is just a nice representative scheme that kind of looks at various parts of the cough reflex and how a cough is initiated. You can see where a lot of these particular cough receptors, say for instance the C fibers and also the rapid adapting receptors and whatnot, are present by the airway epithelium. And then they go through various afferent fibers, mostly through the vagus nerve and through the nucleus tractus solitarius. That's sort of the actual input to what is considered the central cough generator, which is present in the medulla. And so here you can then have efferent fibers that are sent off to various muscles that are involved with the cough response, either via the phrenic nerve to the diaphragm, spinal motor nerves, and also the recurrent laryngeal nerve. And you can then have more or less engagement then of some of the different types of muscles that are involved in cough, and we'll talk a little bit about that. But those are the primary ways that occurs. So you can see that any impairment of this, whether it be some injury to the vagus nerve, injury to the brainstem, or abnormal brainstem development, or other types of nerve impairment, at least from some other type of injury, how that could impair cough. Kind of another way of just steaming through a little bit of the cough pathway. There are a number of stimuli that can trigger a cough, and some of those can be mechanical in nature. So things like a foreign body, which we'll talk about more in depth, dust, mucus, and then also just instrumentation or any type of mechanical inflation or deflation through some mechanical ventilatory methods. On top of that, there's also chemical stimuli for the cough reflex. And a lot of people think of spicy foods, and capsaicin that comes from is the chemical that's responsible for some of that good spice that I tend to like. But that sort of thing can also trigger a cough. Various acids like citric acid, acetic acid. Interestingly here, they've done this a lot with animal models that just nicotine itself, free of any tobacco smoke, can be something that can trigger the cough response. For those of you looking for an argument against e-cigarettes, for those of you that are touting that, that's one thing that you could kind of just relay as well. Osmotic agents or hypochlorite solutions are also known to trigger cough. These tend to be inflammatory mediators that are usually secondary to some other infection or some other reason for chronic inflammation, things like histamine, prostaglandins, those types of things that can also trigger cough. Once one of these stimuli comes through, like we mentioned, it goes through the various cough receptors and through other types of mediators that are present along sort of this afferent intermediary kind of neuronal pathway along the vagus nerve, and again, just kind of going through the cough center in the brainstem to then the effector muscles. Interestingly, here in this slide, they talk about the pelvic floor muscles, which a lot of people don't think about in terms of cough, but people that have chronic cough for long periods of time, a number of them actually develop some type of urinary incontinence because of pelvic floor weakness that can develop with time. If you think about it, some people use sort of a Coke can analogy, where you need to have a solid bottom of a Coke can for the top part to open up and pop. And so if you have a weak pelvic floor, you may have a weak type of cough, and actually the perineal muscles and other muscles are engaged in any type of cough in most people. So just something to kind of think about. And if you really have somebody with a chronic cough, it's not inappropriate to ask if they have any urinary incontinence with some of those types of things as well. And so the cough process, some of you guys that have heard my neuromuscular weakness talks have heard me talk about the 3 stages of cough. And the first one has to do with having a real strong inspiration. And so those of you that have seen us go through huff cough principles with kids with cystic fibrosis, you may see us asking them to take in a deep inspiration almost to the point of total lung capacity. So they're at about 90 to 100% of what they're able to achieve. And what that does is that allows for loading with gas in terms of areas behind whatever debris or mucus or other things need to be expelled with a cough. And so getting them up to that TLC is something that's very helpful. Sometimes people are able to sort of breath stack on their own and get their TLC slightly higher, and that's what huff coughing also helps provide. So the more that you can load that gas behind any of the debris that needs to be cleared, the better off a cough is going to be. And so after that first inspiratory portion, the second portion then goes to the compression, which is essentially it's the closure of the glottis. And what it allows for is it allows for buildup of intrathoracic pressure. And so that is aided by the contraction of all the muscles that we kind of had already talked about, at least with musculature in the abdomen, chest wall, and also the perineum, like we talked about in the pelvis. And then finally, the third phase, at least with cough, is then that closed glottis then opens quickly, and there's an explosive exhalation of gas that comes following that. And so the airway is cleared by compression and then also high velocity of exhaled gas. And I'll show you a little slide about how high those flows can actually be. So you can imagine that any disorders that are associated with ineffective cough, such as neuromuscular disorders, kids that are in chronic pain, those that have some central nervous system depression, all of those can impair any portion of those last 3 phases of cough. So something to always think about: if somebody's not got a good cough, which phase are they really struggling in as you're trying to help tease out their disease? So this is a nice graph just showing at least how expiratory flows in terms of how we expect to see cough expulsion and what kind of forces really do develop. Here are various pressures that are in intrathoracic pressures on the right and also flows on the left. And you can see here that with the inspiratory phase, there's actually sort of that negative flow that comes. And then as you have sort of compressive phase with glottic closure, you can see a rapid increase, at least in terms of both flow and also pressures within the thorax itself. And then as that glottis opens, you see sort of these forceful expiratory flows that can come out pretty much right afterwards. So they've measured actually glottic opening with leading peak cough flows of almost a liter per minute, so fairly high and good and forceful in terms of helping get some of that debris out. So there's a handful of characteristics that are associated with chronic cough, and these are sort of like kind of fall into the buzzwords that kind of show up on board exams and other things like that that oftentimes are in the question stems and those other types of things that are somewhat helpful in terms of pointing you guys in the right direction for answers along those lines. But it also does help distinguish, as you guys are formulating differential diagnoses with these kids with chronic cough, maybe what the underlying source may be. And so kids that have a loose and productive cough, the types of conditions that you tend to associate with those tend to be cystic fibrosis, those kids that may have bronchiectasis from a non-CF source, such as like primary ciliary dyskinesia, or protracted bacterial bronchitis, which we'll talk about, which is something that not everybody necessarily thinks about, but is a known entity that the pulmonologists tend to see, and we'll talk about maybe what that exactly is. Croupy cough, like you guys may see with the classic laryngotracheal bronchitis. Those kids that have paroxysmal coughs, they tend to also have cystic fibrosis or a pertussis syndrome, which we know is coming back with abandon lately. Foreign body inhalation, mycoplasma, chlamydia types of infections tend to have more of that paroxysmal feature. Some people may hear, or it's kind of difficult to really kind of describe a brassy cough, and I use this more for sort of kind of question stem purposes and in board review. But if you ever hear brassy cough, tend to think large airway and trachea. In particular, it's used in descriptions of tracheomalacia and the cough that's associated along those lines. But some people can also see that at least a little bit with a psychogenic or a habit cough, just because sort of the weird kind of sounds versus brassy sounds. Some people really aren't sure how to kind of delineate between the two of those types of features. If you have a tendency to have chronic cough following feedings, you can think about pharyngeal incoordination, some type of pharyngeal or laryngeal mass, and then also tracheoesophageal fistula and gastroesophageal reflux tends to be more when that tends to occur. There's also nocturnal cough, which tends to be associated with upper respiratory tract disease, sinusitis, asthma, cystic fibrosis, and gastroesophageal reflux. If there's any take-home that I can send you guys with today with assessment of chronic cough, it's really engaging your parents to try to tease out, is the cough really present when they're sleeping soundly at night? And if it's something that's not, that tends to go more into sort of a supratentorial or habit cough types of considerations or psychogenic cough that I think is really important for parents to tease out, because oftentimes they don't really know if something is present at night or not, but oftentimes you're able to really tease out any type of weird kind of noisy breathing sounds or even cough. Really try to tease out if it's something that happens at night, because that tends to be where there's more pathology. Coughs that are most severe in the morning tend to be related to cystic fibrosis or bronchiectasis, when some of those mucoid secretions may kind of form and other things along those lines. And then as soon as they get up, they feel the increased flows and they feel the need to clear out their lungs. That's when they tend to have their cough. Coughing that's present mostly with exercise can be seen with asthma, cystic fibrosis, bronchiectasis, as I'm sure you guys are aware. And then kind of we get into sort of the bizarre types of sounding coughs and the loud honking types of coughs. Those tend to be more the psychogenic or the habit coughs. And yeah.
I can't remember, why is asthma coughing specifically with kids nighttime? Like, what is it? I mean, you would think during the day with more irritants and all that, it would be worse.
So with sleep, there tends to be, in particular REM sleep, there tends to be an overall diminishment of respiratory airway tone. And so any kid that's got sort of a chronic inflammatory condition like asthma, that's already got sort of a kind of a reduced patency of their large and small airways, in particular their small airways, any feature where that smooth muscle tone tends to be a little bit reduced with REM sleep or other types of forms of sleep, you can imagine why that would cause a little bit more additional narrowing too of the airway itself. And so the symptoms tend to come out a little bit more along those lines because obstruction tends to be a little bit worse. There could be a little bit more opposition of the airways to themselves and so on and so forth. So, but again, key point, just psychogenic habit cough tends to disappear with sleep, and it's usually one way that you can kind of help tease that out. Oftentimes in our pulmonary clinic, we can diagnose habit cough before even seeing the patient down the hallway, waiting in our office as they come in to see us, because it's usually a teenage patient that is just having just, whoa, that is a bizarre sounding kind of cough, and you guys can tease that out in your offices as well most of the time. So general principles, at least with chronic cough, for the most part, viral upper respiratory infections are by far the most common cause. And then other common causes include asthma, protracted bacterial bronchitis, which we'll have a slide on that here shortly, allergies, sinusitis, postnasal drip. There's irritative causes, as usually for the most part by some environmental tobacco smoke exposure or other kind of environmental effects. And then other infections tend to play a role as well. Some of the more less common causes tend to be things like foreign body, abnormal clearance, immune deficiency, and then you get into your congenital abnormalities. And I would probably put reflux kind of more up in this kind of more common rationale. But that said, there's some general principles for you. This is sort of a nice little slide that helps at least look out for those potentially serious disorders that you may get associated with chronic cough. That should always be in the back of your mind anytime you're evaluating these kids that have had cough for a few weeks up to a couple months. As you guys know, many of you guys that have done months with us recognize cystic fibrosis with the investigations, including sweat testing and also cystic fibrosis and the CFTR genotyping. Immune deficiency, where investigations would include looking at a differential in your white cell count, lymphocyte subsets, immunoglobulin concentrations, antibody responses, neutrophil function. Primary ciliary disorders tend to be something you think about, especially if on top of having some chronic cough, kids have tachypnea. That tends to be a key feature of primary ciliary dyskinesia. But with that, ex vivo studies of ciliary ultrastructure and function that usually requires some type of bronchial brushings that can be done with a bronchoscope or with some type of ENT procedure where they can allow for that. But now you can do that also non-invasively with nasal nitric oxide, which tends to be relatively reduced in primary ciliary dyskinesia. Persistent bacterial bronchitis, which again I'll talk about in a minute. Bronchiectasis, which can really be teased out initially by chest radiograph, but oftentimes needs a high resolution CT to help really tease out where the focal nature of bronchiectasis may be. Those that have some type of GI contents or recurrent aspiration, whether it be from a laryngeal cleft, a tracheoesophageal fistula, swallowing incoordination, neuromuscular disease. Those types of studies can be teased out. Here at Glennon, we say that modified barium swallow and video fluoroscopic swallow studies are essentially the same thing. It's not like that everywhere you guys may wind up. But that said, the modified barium really looks at the esophagus essentially. The video fluoroscopic is classically what looks at sort of the penetration and also oral pharyngeal responses and things like that. But here at Glennon, they kind of look at both of those with the same kind of interest. Bronchoscopy sometimes helps that out with lipid-laden macrophages, and then also various pH and impedance studies, which we really don't do the impedance studies here at Glennon. We send to other centers to help get that, but sometimes that is helpful for looking for non-acidic reflux. Retain inhaled foreign body, which we usually tease out with rigid bronchoscopy and also some type of imaging types of studies. Tuberculosis is something to always kind of keep in the back of your mind, especially if there's a family member or some close contact with a chronic cough. And with them, you really need to kind of go through the stepwise process, which can include as much as bronchoscopy, interferon gamma release assays, so on and so forth. And then the anatomical abnormalities, which usually if it gets to that point, they've been referred to a pulmonologist to help tease that out and really to help assess whether or not there's some congenital lung malformation or other things. But oftentimes they show up incidentally on chest x-rays on otherwise healthy kids that you weren't expecting. So that's also something that we see fairly commonly. Interstitial lung disease is something that's becoming more and more recognized here over the past few years, and there's now the development of sort of rare disorders and interstitial lung disease that now they're starting to actually get multi-center types of registry data on those types of patients. And so we're seeing more and more of this with sort of mild lung disease at younger ages. And so something that you guys will probably see more of as you go through your career. And then, of course, cardiac disease, which is something where that can help be teased out by chest imaging and also echocardiography. So in terms of the ways that they sometimes help, good call, stepping on that. Good ways to help kind of tease out from a board exam type of scenario where there's a chronic cough that's being asked is to really try to help tease it out based on infant, preschool, and school age in terms of maybe where there would be a tendency to have certain differentials that may differ. And so in the infant, you're going to have more your congenital anomalies that are going to become apparent. Certain types of infections that are more prevalent, at least in the early kind of time frame, things like CMV, chlamydia, even pertussis, and those types of things tend to be in more of the younger children. CF, because we're seeing more, about 95% of those now are being diagnosed by genetic screening, but that said, there still can be a later presentation, but when I say late, it's usually within the first 2 or 3 years of life. Interstitial lung disease usually rears itself within the first year of life or so, and then environmental tobacco smoke and reflux tend to be causes then. Preschool, things tend to change a little bit, where if anything, you start to see a little bit more kind of the foreign bodies that can start to develop. You start to see asthma emerge as a little bit more kind of clear cut, as opposed to just sort of the wheezy bronchitis that's gone on a couple times within the first year of life. They can certainly be triggered by irritative sources, including tobacco smoke. But the preschool age is when we start to see this protracted bacterial bronchitis a little bit more. And then as the school age years continue to go on, there can certainly be asthma-related symptoms. Mycoplasma tends to be a little bit more prevalent in that age. But that's where you start to see really the habit cough sort of come into play if you're thinking about your differential along with, again, protracted bacterial bronchitis. And like I said, CF is something that is almost rarely now getting diagnosed within the school age years. It's something that's picked up well before that now. But classically, that's something to think about if it hasn't been tested for, or if it's a patient that's coming in from another country or whatnot. So at least with congenital and neonatal infections, like I mentioned, chlamydia, things to think about, RSV, rubella infections. This is human metapneumovirus, which is similar to RSV. It just tends to have a little bit more of a protracted course, upwards of 6 to 12 weeks. And then also various bacterial causes where pertussis could be particularly harmful at this particular age. And then pneumocystis as well. At least in terms of congenital malformations that we think about, I have vascular ring highlighted here because we've got a case that kind of helps show some of that here in the next few slides. But tracheoesophageal fistula, airway malformations, and then pulmonary sequestration, where there tends to be some abnormal vasculature to a particular lung lobe that may not be fed by a particular airway or so on and so forth. And so here's a case presentation of a 7-month-old that had chronic cough, congestion, wheeze, and noisy breathing since about 3 months of age. Really, it's something that didn't seem to change at all with position and was better while asleep. However, there was no cyanotic or apneic episodes. Albuterol was tried, but was really of no benefit. And the neonatal period was uneventful. In particular, we think about things like whether the kid was intubated, if there was some mechanical trauma, or other things like that that may have happened in the early periods. That said, social and family history was unremarkable. This kid had pretty okay growth parameters with normal saturations. And on evaluation and physical exam, really there was some harsh, noisy breathing, but really no wheeze or crackles. We tend to think of stertorous breathing, which is more sort of the snorty upper airway types of snory type of sounds that you tend to get, as opposed to stridulous breathing, which is more what you describe as stridor. So more kind of the upper airway transmitted sounds, but no clubbing. And so at least here on chest x-ray, you can see that there might be, if anything, just a little bit kind of widened markings here, but aside from that, there's pretty much no infiltrates that we're recognizing. There doesn't seem to be too much in terms of hyperinflation or whatnot, and a fairly normal heart size. But further workup for this child, when you're looking at the AP and lateral, you can see that there is actually, with the air column that's present with the trachea, there can be actually some indentations that you start to see here with a little bit of anterior kind of compression. And also, it seems as though it's a little bit bowed out compared to what you would see with a normal trachea. And so this prompted people to take a look, at least with bronchoscopy, and sure enough, this kid had the typical, you ever see triangular shaped or tent shaped, at least when they're talking about this on a question stem, it's always something to think about a vascular ring. And so here you can see that there's actually compression here along the anterior wall, and there's actually, if anything, a little bit more of a pronounced kind of posterior wall type of bulging into the airway. And so you can see where this could cause some impairment and large airway obstruction, and so on and so forth. And also here, this is with the barium swallow, that usually with things like a double aortic arch or other things where there might be a posterior compression of the esophagus, that can also be somewhat helpful in terms of teasing out what type of vascular anomaly there might be within the airway. And this is a nice little schematic figure of these types of vascular rings. And so it really can get broken down into three major types. Some people you could add that pretty much spectrum is fairly long if you get into the real rarities. But for the most part, if you have a double aortic arch, you can see where that could cause some compression, at least with the blue part here being the trachea. You can see where that would have some impingement there. Also, the right aortic arch with an aberrant left subclavian here, and also a diverticulum of Commerell, which tends to be sort of back more here in terms of helping out behind. Those can cause some types, and as also you can see compression here, that can cause some anterior compression as well. And then last is sort of the double aortic arch, but the left aortic portion is somewhat petretic, and with that there can be some tethering and some kind of compression that can take place anteriorly on the trachea. Kind of going on then in terms of back to these categories. Sorry. Just get back.
If you're staying in the category of infant, if you're trying to tease out in the history, like viral versus when should you, how long, you said studies now are showing more than 4 to 6 weeks of an ongoing cough. I mean, what would kind of make you concerned at 5 weeks as far as the pattern of coughing, let's say a 1-year-old or almost 1-year-old? You just telling them, well, they had, for sure had pertussis or had croup, and this is just going to go on for a while longer?
I mean, usually there will be, even though there's still symptoms, there will be improvement with symptoms over the course of those 4 to 6 weeks. Kids get viral respiratory infections
upwards of 12 to 13 times, sort of like almost run into the next viral infection with each one that they tend to be clearing. It's just if it tends to be prolonged and it doesn't seem to be getting better at all over those 4 weeks, or it seems like the cough continues to be wet, if fevers tend to persist, if there seems to be other types of just abnormal features, like there's stridor that's going along with that seems to be longer than usual, or there's it tends to be really bad at night, or it's always associated with after feeds. Those are the types of features that you try to tease out as you're trying to figure out everything else that might come with a little bit of a wheezy illness, a little bit of a loose kind of productive cough that's coming 2 to 3 days after like a low-grade fever or things like that. And so really seeing that and teasing out that they've gotten somewhat better but not really back to baseline over those 4 to 6 weeks, I think is still pretty reassuring for most families. And so
I feel like I see it all the time, and I try and do the reassuring, but I don't even know if I'm reassuring myself sometimes that if 8 weeks out they have a harsh sounding cough, if you can say that it could be residual, even though they're much improved, that it could go down the route.
Right. And I think at that point, if it's that far out, if it's pretty low yield, low threshold for me to get a chest X-ray and at least start to do some of the other initial portions of a workup, most of the time they're going to be normal. The value these days, too, at least with acquiring a viral PCR and doing a respiratory viral panel, is immensely helpful in our book. It's something where I know it's not necessarily going to change your management, but it's going to provide reassurance for parents, and it's going to give you guys perspective in terms of what at least you should expect along the lines of a timeline. So we get respiratory viral panels all the time, and that's something that I would encourage you guys to do if you're really trying to help tease out that kid that's like 6 to 8 weeks, and it's like, okay, what's going on? Is this something new, something that we need to be more worried about, so on and so forth. And then if it comes back completely normal, then you can work up further. So kind of moving on to other congenital malformations. Airway malformations are something that we do see fairly commonly, at least in our clinic, but not uncommonly with you guys out in the primary pediatric world or other subspecialty clinics. This is a case presentation of a laryngeal cleft, and so here we have an 8-month-old boy with a history of cleft lip and palate that had some mid-face and frontal nasal dysplasia, admitted after the 3rd episode of respiratory distress, fever, wheezing, and pneumonia. And this kid had persisting cough for several months, well, along with some choking that went along with feedings. The patient was failure to thrive at admission. PPD was done and was reported to be negative, and then the child was hospitalized a few months earlier for an influenza A pneumonia. Weight is less than a 5th percentile, so not really thriving like we mentioned. And then there's also some dysmorphic features that go along, including hypertelorism, low set posteriorly rotated ears, and a cleft palate. There are really few inspiratory crackles with mainly some large airway transmitted expiratory noise, some wheezing, no clubbing, and the immune workup in PPD was found to be negative. With these kids that have laryngeal clefts, you almost always notice some type of mid-face abnormalities. You're going to have some flattened nasal bridging or sort of a wide space type of philtrum or something else that just doesn't seem right. And if you do see anything along those lines with an abnormal mid-face and they're having sort of this aspiration-like type of picture, it's always good to think about laryngeal clefts. That said, as you guys can see here, there tends to be a CT scan with some abundance of more basilar types of infiltrates, both left and right, more prominent on the right, which tends to go along where you see sort of this air bronchogram type of pattern, but essentially significant infiltrates that are present bilaterally. And so this child underwent a formal bronchoscopy as well. Important to note is that a laryngeal cleft is not something that's going to be seen by formal flexible bronchoscopy because of the way that the flexible bronchoscope isn't really able to kind of move kind of the posterior laryngeal tissue out of the way. Really, you need to diagnose a laryngeal cleft with a rigid bronchoscope with ENT to really kind of get that teased out well. But here you can see sort of the vocal cords, this being anterior, this being posterior. And normally, whereas those would come to kind of meet each other here and kind of close off the area of the trachea, this does tend to have an open cleft that then kind of goes back into the esophagus. So this is sort of a classic laryngeal cleft. This is an image that shows, at least after a bronchoscopy, when we do a bronchoalveolar lavage on these patients, that they have these positive cells that are stained with oil red O, and these are actually macrophages, or what we call lipid-laden macrophages, so kind of positive for some type of aspiration. So classic with what goes along with laryngeal cleft. And so again, always think about cystic fibrosis when you're dealing with somebody with a chronic cough. That just things aren't totally making sense in terms of other more kind of common causes. At least with a case like this, again, this is somebody that we would not typically see, but we still do see on occasion, where we had a 16-month-old admitted on 3 occasions over an 8-week period for wheezing, coughing, and an O2 requirement. This child was home on albuterol and prednisolone, but didn't really know if delivery of albuterol was taking place at home. Triggers were unclear. Growth and stool history was normal. There were really no aspiration events, no stridor, no reflux symptoms, no skin problems. There was some tobacco smoke exposure, and of course there was some asthma in the family history as well. And of course normal growth and development with the weight at the 50th percentile. But that said, there was some tachypnea, trace retractions, and really minimal expiratory wheezing without clubbing on this. And the main thing to think about here is that with CF, even at sort of the early stages, like this child would be at about 16 months of age, there may not be any real frank infiltrates or other types of signs aside from what you might see with hyperinflation. So here, if you counted the ribs, this is 1, 2, 3, 4, 5, 6, 7, 8, almost 9 ribs expanded, both right and left. And this is typically what you would tend to see with early stage CF. You may see a little bit of perihilar types of markings, and sort of classic question stem type of thing for boards is that kids with CF tend to have predominance of upper lobe infiltrates, at least early on in stages of disease. So if you hear upper lobe, think of things like CF, think of things like tuberculosis, if you think, as opposed to things like aspiration, which is more lower lobe involvement and things of that nature. And so this is really a pretty unremarkable x-ray aside from that, and you may think that this child has asthma just with this degree of hyperinflation, but if it just doesn't seem to be responding to albuterol and other types of things that classically asthma would be covered by, is something that a sweat test would never be, we would never fault you guys for getting something like that in a situation such as this. And then protracted bacterial bronchitis, something that you guys may not talk about every day, but it is the sort of thing that we do diagnose. I probably see about 2 or 3 of these kids a year where we see somebody that really fits this diagnosis well. And so with those kids, they tend to have a chronic wet cough, and if you were to do a bronchoscopy and a bronchoalveolar lavage on these patients, it would be pretty pronounced that you would see this neutrophilic response, and also some of the more classic kind of respiratory pathogens like strep pneumo, H. flu, Moraxella. This is oftentimes diagnosed as asthma. However, it really sort of has sort of a blunted albuterol response again, and doesn't seem to respond as well to either oral or inhaled corticosteroids. And so that said, these patients do seem to respond briskly to certain types of antibiotic regimens, and oftentimes the antibiotic regimen needs to be protracted as well, so upwards of 6 weeks to 3 months, and where you see an actual real benefit. That said, this is something that is not entirely well characterized, though there's a few recent literature reviews that have been looking at this a little bit more closely, in particular with interleukins and other things that have engaged this process. But there's probably some type of inflammatory process going on in these kids that leaves them prone, but more to be determined. So foreign bodies are something that you see on occasion here as well, and they're always fairly interesting, and there's always some interesting backstory that tends to go along with them as well. And so, along those lines, the case presentation for a foreign body, this would be a 12-year-old boy with a past history of asthma that developed a new cough and wheeze over 2 months. So the key part with this is that they tend to be healthy, and then for some reason there's this, there's this event that occurs where all of a sudden they seem to be far worse. There was a questionable aspiration event with a big pen in the mouth around the time of onset of symptoms. There were several courses of antibiotics that were given, and also 2 courses of oral corticosteroids that did not seem to relieve the cough. And there were also some past episodes of wheezing cough that were maybe responsive to asthma meds and antibiotics. But again, with this one, at least on physical exam, it's pretty much just remarkable for diffuse bilateral wheezing with fair air movement. But really the rest of the exam was fairly normal. Past medical history, no hospitalizations, really nothing else that seemed to jump out. So a chest x-ray and PFTs were performed on this child. And as you can see with this one, similar to what we were talking about with that past cystic fibrosis patient, you really wouldn't say that there was too much remarkable about this chest x-ray aside from the fact that there is some bilateral hyperinflation going on here, which I think you guys can all recognize. And it almost seems as though the heart is small because of how hyperinflated the airways are. And we'll show you here that that's something that is not all that unusual with foreign body inhalation. And so you can see here then also on sort of the lateral view that there does tend to be a little bit of an increased kind of air sort of anteriorly and mediastinal kind of component. And you can see a little bit of flattening of the diaphragms with this lateral view as well. Now that said, this is sort of a little bit misleading in the sense that is this asthma, because there tends to be at least a brisk bronchodilator response where you see the increase in both the FEF25-75, which indicates small airway involvement. You can see sort of a robust response to bronchodilators there, and also a robust response to the FEV1 or large airway obstructive types of features where it seems like albuterol does seem to provide some benefit. That said, there still are some features that are consistent with obstructive lung disease. And also you can see that what's interesting is that with the albuterol, not only are you getting improvement with the expiratory limb of the flow volume curve, but you're also seeing a robust improvement with the inspiratory portion of the flow volume curve. So that's not something that you typically see with asthma. So with that being a little bit unusual, it was what prompted going ahead and doing bronchoscopy. And sure enough, there was a foreign body in the right middle lobe that tended to be the base of that big pen that the child was, kind of just playing around with and whatnot. So always something to kind of think about along those lines. Out of Memphis, they did a retrospective review of 155 cases of foreign bodies and really what types of things tended to, what kind of trends did they see. You can see here that the majority of the patients were between 1 and 2 years of age, where that was upwards of a number. That said, you can see that as in those kids that are less than a year, and you can always see it in kids that are greater than 6, like this patient that we just had. 83% of those had an aspiration event that occurred within the last 14 days. And of those, in terms of where you tend to see them have the foreign body when they ultimately look for them, most of them show up in either the right main stem bronchus or the left main stem bronchus, where 10% can really be found at least in the trachea. And so of those, tends to be a little bit of a predominance for males to have this happen for whatever reason. And so at least with what they found radiographically on some of these patients, there tends to be sort of that hyperlucency. And actually, one of the strongest, kind of most sensitive findings, at least in terms of looking at a patient before doing bronchoscopy and actually finding a foreign body, is whether or not there's a choking episode that was observed by a parent. And then just behind that would be something along the lines of unilateral hypolucency, which is really sort of a strong indicator that there tends to be a foreign body that's present. You also see certain key trends, at least with atelectasis, Whether or not a chest x-ray can be normal, that's actually found in about 20% of these patients that have a foreign body. So if you're thinking about it, but you have a normal chest x-ray, that doesn't really rule that out. Same thing goes with whether or not the foreign body is opaque and something that can be easily seen on a chest x-ray. You can see for the most part that that doesn't tend to be the case. It tends to be more radiolucent, if anything. And then a few of the other more kind of extreme kind of cases in terms of what you said. And so, again, 20% had normal chest x-rays with foreign bodies that were found. And then kind of going on to like sort of a final case where we had a 14-year-old girl with an 8-month history of cough, with a cough that was described as loud, barking, disturbing to schoolmates and family, really no coughing at night. Family notes you can hear it from one end of the house to the other. Seen by a pediatrician multiple times and treated with amoxicillin, augmentin, plenty of antibiotics, plenty of bronchodilators, courses of steroids, so on and so forth. ENT saw that there was maybe some sinusitis by CT scan, but really augmentin did limited help. And an allergist was referred to where skin testing was negative and nasal steroids were of no help. And with this kind of case, they oftentimes show up in our clinic because we kind of go through the history, but ultimately we're getting more of a formal review of imaging, and also we're getting official pulmonary function tests to see if there's anything that's present. But we have a kid here that has a fairly normal FVC, FEV1, and also FEF 25 to 75, and no bronchodilator response that was seen. So this classically goes with had the cough. And so something to kind of think about in terms of that, with the key feature being that it really wasn't present at night. Just reiterate that portion. This is a nice slide just to kind of show you how to really evaluate chronic cough in children. And so you have whether or not symptoms and signs of respiratory disease are present, yes or no. Whether or not a chest x-ray or spirometry is abnormal, yes or no. Whether or not a cough is characteristic. And I would actually put in here that you could put an extra part that said whether or not a cough is present at night, in terms of helping you guys along the lines of this algorithm to try to help guide people. And so with this sort of questionable, non-specific cough, usually a period of time where you're watching and waiting and seeing what things may be going on is usually helpful. But then you always evaluate for certain types of environmental exposures, what the child's activity is, what the parents' concerns are, and if maybe they're a little bit excessive in terms of certain things along those lines. And then treat obvious illnesses if they're present. If there tends to be more of a specific cough, we'll have more of an algorithm for that here in a short bit. But that said, if there really aren't any signs and symptoms for that, continue to watch. If there's a persistent cough, continue trials of therapy, watch, wait, or review. But really, the trials of therapy should not really extend beyond 1 or 2 courses of either of these before we would say empirically that that doesn't seem to be working. And so we really shouldn't be getting into 3 or 4 courses of antibiotics. We shouldn't be getting into 3 or 4 courses of oral steroids before we really start to think of other things. That said, if we do get into that sort of specific cough pathway, one way of kind of looking at that again is to then do some spirometry, or whether or not you can do some courses of albuterol in the office, and whether they have physical exam findings that have changed with that. And so if they do have reversible airway obstruction, or one more formal way that we can do this in the PFT lab is to look at exhaled nitric oxide. If they have an elevated exhaled nitric oxide or this feature, that can be consistent with asthma, and you can go forward with treating that as you see fit. If it doesn't seem like any of that is present, then you assess risk factors for all those other things that we've kind of already referred to. And if it seems as though those parts become difficult to really assess just in a primary care setting, that's when referral seems to be appropriate to either us or allergy, but we would prefer to us. That said, with treatment options, at least for chronic cough, really direct therapy at the underlying cause after you've helped tease that out. Very few patients ever require any type of antitussive. We have a slide for that coming up here. If there's no specific etiology recognized, you can do sort of a therapeutic or diagnostic trial of inhaled corticosteroid or beta agonist. But again, the key part of that is that you really don't let that kind of go on too long. That should be something that you see a fairly good response to within 4 to 6 weeks. And if it seems as though that doesn't seem to be the case, that's usually something that's a red flag to kind of start thinking about other things in the course of a chronic cough workup. There are the various antitussives that are out there. I had a patient that came in to see me with essentially just environmental tobacco smoke exposure and viral-mediated cough that I saw yesterday that was on codeine kind of cough syrups, and it was just the sort of thing that is something that was way in excess and something that could be kind of problematic in terms of something where it's usually easily kind of managed. That said, there are the non-narcotic antitussives. And all of these act through a central cough center in the medulla, which is very different than kind of treating the underlying source for many of these patients. That said, there was a kind of a huge study that was done back in 2004 that looked at the effects of a variety of these antitussives, including dextromethorphan and also Benadryl, versus placebo, at least on nighttime cough and sleep quality for coughing children and their parents. And this is sort of a kind of arbitrary subjective scoring system for the severity of how they felt each of these particular questions were. So, for instance, how their cough frequency was, how cough was bothersome to the child, what the child's sleep was like, and what the cough severity was like based on parent perception. And you can see here that for dextromethorphan, this is dextromethorphan, diphenhydramine, and also placebo. That first night when they got home after receiving a treatment, they all kind of sat up sort of in the same type of subjective categorization. But interestingly, after that second night, they all did get better, but they got better despite the fact that they got diphenhydramine, dextromethorphan, or placebo. So there really was no kind of added benefit of any of these antitussives relative to placebo for the subjective perception of parents, at least in terms of helping their children out with their just subjective quality of life at home. So again, just something where it seems as though there's an overprescribing of these particular meds when it comes to chronic cough, and it oftentimes obscures at least the chronic cough workup and what's appropriate in targeting the source of that in the first place. So in terms of other things, just as my last slide here, just in terms of other things to consider for treatment options, gastroesophageal reflux disease is something that we do tend to see some improvement in chronic cough for those patients that we really do have a strong suspicion for some type of reflux component. They can be used with PPIs or H2 blockers. Pertussis, there's certainly therapy that's more kind of set up for that. Mycoplasma disease, you really want to consider particular antibiotics that target those particular pathogens. But then speech therapy can sometimes be helpful for those patients that do have habit cough, or even if they have a component of vocal cord dysfunction, if that seems to be something that brings out a little bit of cough aside from just paroxysmal inspiratory kind of vocal cord closure, they can often be helpful with certain types of relaxation exercises and things to help with alluding to that. But also, some of you guys may have come across just like medical hypnosis and other types of things along those lines. And actually, there does tend to be an incredible value in hypnotic therapy for types of features like habit cough or other types of things where it seems like that's sort of the subconscious that they just can't seem to get over that during the course of a day. So oftentimes I'm seeing more and more pediatricians that are becoming trained in hypnosis therapy, and they're finding that to be quite helpful. That said, usually with kids with habit coughs, the best thing that you can do to kind of help tease that out and help that get better is to confront the patient and really just say, look, we think that there's very limited kind of things going on pathologically, at least with your lungs. We think that there might be sort of a habit kind of forming kind of that may be developing with this. And usually if you call them out on that, it's amazing how they tend to get better with that over a period of time. And so, and it's not to be kind of there to agitate them. It's not to really try to cause any conflict. It's just there to kind of put it out on the table, and oftentimes it works. And so, aside from that, I don't have any other slides. Do you guys have any questions? No? You guys that I won't see again, good luck. All right, congratulations. And so, thank you guys.
Thank you.